Hello everybody. A short run through of the current state of the prostate MRI pathway in 2024, a radiologist's perspective. These are my disclosures. Okay, so many of you will have seen the latest EAU early prostate cancer detection pathway, which is risk-based. And you can see that in this risk-based pathway, MRI comes in at two places. One, for risk stratification of men who are initially assessed clinically, and also here on the right-hand side for biopsy planning. And this is to be used in men who are in the early detection pathway, who may or may not be symptomatic, and they have a reasonable life expectancy. So in these men, what advantages does the MRI-based pathway bring? And there are four main advantages. The major advantage is reduction in the number of patients undergoing a biopsy and a reduction in the number of indolent cancers that are detected, and this relates to the negative predictive value of the MRI pathway. But there are also benefits from the positive predictive value, and that is to say more accurate diagnoses of cancers, particularly in tumor grading, and there's a slight superiority for the detection of clinically significant disease in biopsy-naive men, and also in men who have had a previous negative systematic biopsy. Now, the benefits on the right here need to be balanced by the harm. And the harms obviously arise from false results, and the false results include false positives and false negatives. So a false positive harm, for example, is an unproductive biopsy or the over-detection of clinically insignificant cancers. A false negative harm is a missed important cancer and a delay in the diagnosis. And of course, there are other challenges for the delivery of the MRI pathway. Some of these are outlined over here. It seems as though too many men need an examination. There are too many indeterminate scans, and we'll come to that. And there are too many unproductive scans. So unproductive biopsies. So how do we begin to deal with these challenges? Well, the first thing to do, of course, is to choose the right patient. And if you look at the EAU guidelines on the left-hand side, you can see it suggests for early detection, you may pick men who are symptomatic or asymptomatic. And a typical patient will be somebody like this. So you can see a gray zone PSA, so elevated between 4 and 10 with a negative DRE. This guy is very typical for the sort of man who should be getting an MRI. And of course, you can see that PIRADS 5 lesion anteriorly in the prostate gland. Now, of course, there are other patient groups who need an MRI, and these also include men who have had a prior negative or non-explanatory systematic biopsy. And these have been the two traditional groups. But we now see other men needing an MRI. So, for example, if you avoided a biopsy in the first place after a negative MRI and your PSA continues to rise, then you clearly need another MRI. Or if you had a positive MRI and you had a biopsy, but it was negative and you have ongoing concern, then you clearly need another MRI before another intervention. And we are now seeing people on active surveillance also needing MRI. And in the future, we can anticipate that those men who are on a screening program will also need a prostate MRI before a biopsy. So these are the sorts of men that will need an MRI. The next thing you have to do is to do the right MRI for the right patient. This statement by the PIRADS committee still applies. Both unenhanced and enhanced MRI approaches are needed before undertaking a biopsy. So as the EAU guidelines clearly continue to state, those men with an intermediate or high-risk prostate cancer should get a multi-parametric MRI with contrast medium. Clearly, if you have a very obvious carcinoma and you have a very high PSA, then you don't need a prostate MRI, a prostate with MRI with contrast. And if you're very low risk, somebody in the screening setting, for example, you do not need to give contrast medium, because in that situation, you just promote overdiagnosis of cancer. Now, this is being strongly challenged by this study, which has just recently been presented at the EAU. And you'll see that this was a prospective international study in about 500 men. The important thing to remember is that the majority of these men were of intermediate risk. So what the PIRATS committee would say needs a multi-parametric MRI. But you'll also notice that the majority of the scans were done at 3T. And the image quality was very high, with a Pequot score of 5 in over 70% of patients. But even in this situation, you can see that the dynamic contrast enhancement did suggest additional biopsy targets in about 6% of patients. But if you look at the overall outcomes, what you notice are identical outcomes. So the detection of clinically significant disease is no different. The detection of insignificant disease is no different. And the false positive rates are also not that different. So it looks like this high-level data is suggesting that biparametric MRI is as good as multiparametric MRI, but when data quality is good, number one, number two, highly expert readers, and number three, MDT decision-making. Now, what about biopsy cause in men with a negative and a positive MRI? So let's have a look at a typical man with a negative MRI. So here is a man with a huge prostate gland. You can see over 200 cc's. This is clearly a negative scan. So the question is, would you advise a systematic biopsy because his total PSA is raised, although his PSA density is in fact quite low? Well, if you were to do a systematic biopsy, you'll see that about 74 of these men would have a negative biopsy. So a biopsy that wasn't worth doing, and of course the exposure to the side effects of the biopsy. You would also overdiagnose 18 men who would have clinically insignificant cancers. But you would diagnose these 8 men who have clinically significant cancers, if you say grade group 2 and above is clinically significant, including 3 men with these grade group 3 and above. So you can try to surmise that benefit-harm ratio in this kind of graphic. So you can see that 92 men would suffer harm following a systematic biopsy in the negative MRI situation for 8 men who get a benefit. Now, is this worth having? That's the key question. Now, if you were to follow these men and not have a biopsy, what would happen to these men over time? Well, a couple of observational studies have looked at a lot of men. You can see over 4-5 years. And of course, clinically significant cancers will emerge. And you can see that in both of these graphs. But is it dangerous to have a delay in the diagnoses of these mostly grade group 2 cancers? And it turns out in prospective studies looking at the long-term outcomes of men diagnosed with grade group 2 cancers over time, you can see that there is very little in the way of a mortality detriment in a delayed treatment. There is a slight increase in the degree of development of metastatic disease, I'll grant you that. But over 17, 18 years, the mortality differences, in fact, are the same. So what can you do about trying to detect these men who might have clinically significant cancers? The urological view is that you take into account the PSA density in addition to the negative MRI. And you can see if your PSA density is less than 0.2, the chance of you having a clinically significant cancer on a systematic biopsy, you can see that, is much less than 10%. So these men can certainly avoid an immediate biopsy. And if you took that cutoff of less than 0.25, are you at an elevated risk compared to the background population? And it turns out, no. If you look at this recent data that's just been published, you can see that if your PSA density is 0.5, 0.15 or less, then your background, your risk of having clinically significant disease is in fact very close to the background level, depending, of course, on the population. If your PSA density is higher, then clearly you are going to be at an elevated risk of having prostate cancer. So if you have a low PSA density, then you're basically pushing down the chance of you having a clinically significant cancer. And if you look at the EAU guidelines say exactly that if an MRI is negative, in other words, PIRADS 1 or 2, and clinical suspicion is low, and the cutoff that they've used is 0.2, and there's no strong family history, then you can omit the biopsy and offer PSA monitoring. And in fact, this is also recommended by the radiological guidelines. So here is a paper that's recently published on how to manage men with a negative MRI. So if you are at high risk, and high risk is shown here on the left-hand side at the bottom, you can see that if you have high PSA density, West African ancestry, a strong family history, then you should consider a biopsy. And because there is no target, then you do a systematic biopsy. If you are not at elevated risk, then you can avoid an immediate biopsy and you follow the guidelines that are applicable in your own setting. The important thing is that clinical surveillance has to have triggers for re-imaging and re-biopsy. And the trigger that we use in the UK is shown here. You can see a patient is discharged to primary care if the level of suspicion is low, advise PSA follow-up at 6 months and then every year, setting a PSA level for primary care to re-refer the patient based on a PSA density of 0.15. So that's a very clear guideline about when they want patients to be re-referred for re-imaging and re-biopsy if recommended. Now let's take a man with a positive MRI. So here's that friend of ours that we saw earlier. Now, the issue that I'm going to raise with you here is what sort of biopsy should this man have for that focal anterior lesion? Should it be a systematic biopsies? Should it be targeted biopsies? Should it be systematic plus targeted biopsies? Regional targeted biopsies? So what is the trade-off, essentially? What is the trade-off between performing targeted biopsies alone versus targeted plus systematic? That is the key question that we want to address next. Well, if you were to do a targeted biopsy, you will detect 39 important cancers, grade group 2 and above. But you would also detect 16 indolent cancers with just a targeted approach alone. Now, if you were to add a systematic biopsy on top of that target, you would discover 5 additional clinically significant cancers. But you would also diagnose 4 additional indolent cancers. And that, my friends, is the crux of the matter. For every man undergoing a combined biopsy, every additional clinically significant cancer needs to be balanced with a clinically insignificant cancer. And that is the balance that urologists are always struggling with. So why is it that these targeted biopsies are missing significant cancers? That's a reasonable question. Well, it could be that we as radiologists don't see a lesion, okay, or they may be hidden, they may have a cribriform pattern, and we know we have radiological observation as well as misclassification errors. As radiologists, we make these errors. But what about lesions that are seen by us? Well, that's often down to the urologist because there are targeting issues. How do you get to that lesion that the radiologist has seen? And this particularly applies to these smaller lesions and rather indistinct lesions that radiologists will often point out. And the interesting thing that is now emerging is that you can now not only perform the targeted biopsies, but perform a regional targeted biopsies. In other words, peri-lesional biopsies. And we know that this increases the yields of clinically insignificant cancers and doesn't seem to affect that much on overdiagnosis rates. And it is possible to, in fact, mitigate grade migration bias, which is a lecture for another day. So this is what the EAU recommends. You'll see when an MRI is positive, i.e. PSAD 4 and 5, combine a targeted biopsy with a peri-lesional sampling. So you can see there is no more role here for a systematic biopsy as in 2024. So peri-lesional biopsies. How many biopsies do you do? Well, still not defined, still not very clear. It is likely that if you have a large lesion, PSAD 5, clearly locally advanced, or you've had a previous systematic biopsy already, then you don't need a systematic biopsy core, and you can just use a fewer number of cores. Of course, there will be lesions that require more cores, and these are multiple small lesions, diffuse lesions, larger PSAD 3 lesions, anterior gland lesions where there might be some errors if they have a large gland with a small lesion, and of course if there's a high suspicion, in other words a raised PSA density. Which now brings up the issue of what do you do about PSAD 3 cases, these indeterminate scans. Well, the first question to ask is, how often does this happen? Now, prospective studies, audits, and looking at meta-analyses now strongly show that the proportion of indeterminate scans is about 20% in clinical practice. That's just the way it is. So the study, the rapid study, bottom left-hand side, 4,500 patients looked at in West London. You can see PSAD 3 was 20%. And the meta-analysis on the right-hand side, you'll see again, the prevalence of PSAD 3 was about 1 in 5. Okay, so in these PSAD 3 cases, how often do you get clinically significant cancers? And it turns out it's about 1 in 5. Okay, so that's easy to remember. 1 in 5 men who are on the early detection pathway will have a PSAD 3. And 1 in 5 of those men will have clinically significant cancers. So what do you do about these PSAD 3 cases? Well, the important thing here is to first of all ask a friend. And ask your friend, your colleague, what's the quality of my scan? Is it good enough? Okay. Now, if you have a poor quality scan, you can see here on the bottom, do not call it a PSAD 3 because the quality is poor. In fact, that scan should be junked, and you should really call this PSAD 0. And of course, PSAD 0 doesn't exist, but this is a recall for another examination. A big temptation to call these PSAD 3 indeterminate, I don't know. But in fact, you should only apply that when the quality is high. Okay? But also get your colleague to do a check of what you've done. So here's a colleague who's saying, there's the DCE sequence. Oops, we forgot to do that. Okay, and when we did it, this is what we see. And a targeted biopsy to that lesion is in fact clinically significant. So are you being PSAD compliant? So asking a friend is a legitimate thing to do, because this is a nice study that was recently published. You can see that the number of PSAD 3 categories in fact goes down with the second opinion. You can see that PSAD 3 categories in this particular instance went down from 209 to 128. So it's worth getting a second opinion. The other thing you do when you're trying to decide who to biopsy or not is look at the PSA density. And you can see on the left-hand side there that the chance of you having a clinically significant cancer, which you can see plotted on the y-axis, is strongly modulated by the PSA density, which is on the x-axis. And you can see that cutoff where that arrow is. This is 0.1. And you can see once you get above 0.1, the chance of you having clinically significant cancer increases by more than 10%. So the PSAD 3 is strongly modulated by the PSA density. And if you were to use a PSA density cutoff of 0.1 for the PSAD 3 cases, you could save about 32% of the biopsy and avoid the detection of about 1/3 of the clinically insignificant cancers, at the risk, of course, of missing some clinically significant cancers. It'll be about 7%. So it looks as though we should be thinking about using PSA density. So we said that anybody with a negative MRI should have a biopsy if the PSA density is more than 0.2. Now we're saying that anybody with a PSAD 3 with a PSA density of more than 0.1 should have a biopsy. And of course, every PSAD 4 and 5 case should also have a biopsy. But what would happen if you undertook this strategy, if you compared that to just the 3, 4, and 5 strategy? And you can see the results here. So this is a large aggregation of data. You can see more than 4,500 men. You'll see that if you did PSAD 3, 4, and 5 and said, that's it, 50% would avoid a biopsy. But if you took this alternative approach, which we just discussed, a PSA density of 1 and 2, the PSA density more than 0.2, a PSAD 3 with a PSA density more than 0.1, and all 4s and 5s, it's identical. Look, 50%, 49%. The number of cancers detected is the same, so the number of missed cancers is the same. And you can see here the unproductive biopsy rate is also the same. You'll see that there, right? So in fact, it turns out that the population outcomes is identical, but each man on the EAU pathway is more individually risk assessed for biopsy. So that is the good way to go. You get identical outcomes, but you will be biopsying different patients rather than applying the blanket rule of 3, 4, and 5, and everybody gets a biopsy. The other thing you can think about is using AI. Now, and this is an example of somebody with a PSAD 3. You can see there's a lesion, a condensation of tissue here. Maybe hyperintense here, but not very low ADC. So this fits a PSAD 3. But the AI says, you know what, there's a lesion here, and I'm 95% certain that this is going to be a clinically significant cancer. So this is asking the AI there. Now, if a radiologist uses an AI in daily reading, what will be the effect? Well, it turns out that it increases the number of negative calls. PSAD 2 and 3 cases increase. It decreases the number of positive 4 and 5 calls. So as a result, you'll see that the number of PSAD 3 cases stays the same. Okay, so AI will call lesions and help you triage, but overall it stays the same. But if you ask the AI alone, it would call very few indeterminate cases, which is interesting. Yeah. Okay, so what do the guidelines say? Well, the guidelines say when an MRI is indeterminate, i.e. PSAD 3, and clinical suspicion is low, and look at the value that it quotes, 0.1, and there's no other high-risk factors, omit the biopsy and offer PSA monitoring. Okay, so you need to be thinking about the safety net of men avoiding a biopsy after a scan. And so who is this safety net appropriate for? Well, it's appropriate for men who were deemed initially of low risk who never got an MRI. Men who were considered low risk after an MRI. In other words, PSAD 1 and 2 cases who have progressive clinical PSA kinetics, or somehow clinically you are concerned, but also includes intermediate risk men with a prior negative MRI who did undergo a biopsy, and intermediate risk men who had a positive MRI but had a negative biopsy. So all of these men need a safety net. So what would happen in an intermediate risk man after a prior negative MRI but underwent a systematic biopsy? Well, if you were to prospectively follow these men, what you notice is that over the longer term, we said that the prevalence is not elevated. And if you look on the bottom right-hand side, the prevalence of clinically significant cancers in these men who have had a negative MRI and had a systematic biopsy, right, about 3% will be diagnosed as having clinically significant cancers. In other words, this is not elevated compared to the background prevalence of clinically significant cancers. But what about a man who had a positive MRI and then had a negative biopsy? These men are interesting. So it's not infrequent. So in PSAD 4 cases, you can see that you can have a PSAD 4 lesion, and about 25% of these men will have no cancer diagnosed, neither grade group 1 or grade group 2 or above. And in PSAD 5, it's about 8% in this very large, recently published meta-analysis. So why does this happen? Well, it happens because of false positives. And what are the most common causes of false positives? Inflammation and infection. And in fact, you'll see that acute inflammation is associated with atrophy. And so if you follow these men over time, you'll see a lot of these PSAD 4-5 cases will in fact fade away, become normal. But if you have a persistent abnormality on a serial MRI, then you should re-biopsy these men. So this is what is recommended by the EAU. You can see that if you have a PSAD 5 abnormality and there is no good explanation on a biopsy, then you need to repeat the biopsy. If you're a PIRADS 4 patient and there is no explanation on a histological review, then you may be followed and have a repeat MRI in 3 to 6 months. So we really do need to understand why we get the variations that we see in clinical practice. And it turns out there are a multitude of causes for the variability of test results. Some of it is due to patients. Okay, so this is how big they are, their metalwork, the amount of gas in their rectum. But some of it is definitely due to the medical professionals. In other words, how well the teams are working, whether it be the imaging or the imagers, the urologists and their biopsy methods, or even the pathologists when they are reviewing the scans. And there are multiple factors that we need to take into account and be aware of and then try to control. And you control these variations through quality steps, quality control and quality assurance. And there are 4 principles that you need to apply. One, you need to understand what are the major sources of variability that's affecting your pathway outputs. You need to try to control these through standardization of your procedures, through automation as far as possible, and make sure that you're working well as a team. You also need to make sure that your team members are working well, and that's through their education and even certification. And you need to assure the quality of your process by monitoring key performance indices. So what are these key performance indices? Well, I've just shown some of that here in a longitudinal report, and this was from Sweden. No, this is from Finland. So what you notice is that the practice before and after the introduction of MRI, which an MRI was introduced in 2018. And what you notice in these key performance indices is that there are fewer repeat PSA tests. Okay, a benefit. Fewer biopsies undertaken overall, which is what we were expecting. Fewer negative biopsies, fewer indolent cancers, and more clinically significant cancers. So these are the advantages that we said that you would see if you were to introduce an effective pathway for the diagnosis of prostate cancer. So this is my final takeaway. You have to be very careful about choosing the right man for the MRI and the MRI biopsy, and this is based on their prevalence. And remember, the prevalence that you should be getting in your own clinical practice in the early detection pathway is between 30 and 50%. You need to risk stratify not only your negative men, but also your indeterminate scans for biopsy decisions, and this is mostly done by using PSA density. You need to tailor the biopsy strategies according to the care priorities of your patients and the urologists. But importantly, use the MRI as a roadmap to target the biopsy. You have to accept that you will not diagnose all clinically significant cancers immediately, which means you have to have robust safety nets for men either avoiding the MRI in the first place or avoiding a biopsy after a negative MRI, but even in men with a positive MRI who had a negative biopsy. Finally, you have to assure the end-to-end quality of the diagnostic pathway that you are offering with robust, audited, multidisciplinary working. I hope you found some of these comments useful as you think about how you might implement the pathway in your own clinical practice. Thank you very much for listening.